by pretty much all subspecialties in radiology. And it is a very straightforward MRI. If you look at spine, the indications is in our practice, spine is one of the largest volume of MR which we do, apart from obviously knee and other things. But spine forms a big volume of work we do. Typically, it is reported quite fast. So we all know how quickly the spine MRI reporting happens. But equally, we have to be mindful that small important things can be there which can be missed and can make a huge difference to patients' management. So let's start with this. Is everybody able to see my pointer? Chinmay, are you able to see my pointer?
Yes, sir, but can you choose the laser pointer?
I'll change it to laser pointer.
Yes, thank
Yeah,
you, sir.
I think that's the laser pointer there.
That's perfect, sir.
Okay, so that's much better visible. Yes. So, starting with why do errors happen in radiology? This is a generic slide, and what I would like to tell people is why I keep thinking, we all think, why have the errors been happening? And commonly the reasons are because there is lack of clinical information, which is quite common. We don't have the whole story. Sometimes we don't know there is history of trauma. Are they suspecting infection, tumor? We just don't know exactly what's happening wrong with the patient. Second thing, which is quite common in practices in a number of countries, can be difficult getting prior imaging or reports, which is a big problem, because sometimes patients have been going from different centers to the one center to the other, and we do not know the whole story. The third important reason why it happens is the satisfaction of search. Now, this is a radiologist factor. The other two are non-radiological factors, but this is a radiologist factor, where the radiologist sees one abnormality and focuses too much on that abnormality and stops looking for other abnormalities. The other common thing is the corner findings, where there are abnormalities in the corner of the imaging. And then another very important one is the lack of knowledge, where somebody has not been trained properly and then they are still reporting that particular modality. So sometimes people are able to identify the abnormality. So that's not really a miss. So they identify the abnormality, but they don't know what significance should be attributed to that abnormality. So they are not able to describe the importance of that abnormality or give relevant clinical significance to that abnormality. And that can also lead to problems. And the last is, we will look at some examples as technical considerations where the proper sequences have not been performed. And we will also look at examples of these. And then there is incomplete coverage. There are artifacts in the imaging. Say, for example, there is presence of metalwork or other things, and the proper sequences have not been performed. So, in my opinion, the most important thing to do is identify patterns. That is how I look at the MRI, because if you know what should be there, you're more likely to see it. So your eyes will automatically start scanning. So you see one abnormality and automatically you start thinking, this is what I should expect next. So I see a sternal fracture, for example, automatically I will start looking for thoracic spine fractures. So you train your mind in that way and you'll never miss anything. So in this particular talk, I would like to go by the different themes. Would like to go by trauma theme, disc pathology, infection, inflammatory arthropathy, variants, and then we'll look at various other themes in this particular talk. So what I tend to do is, if I do not find anything to explain the clinical history, so whatever the clinical history has been provided, and I do not find anything in the imaging to explain it, I spend an extra minute looking at the imaging. The next thing is, if the scan looks normal to me on the first review, so I have a first review, it looks normal to me, I spend a couple of extra minutes looking at the whole scan before I sign it off. And we need to have a systematic pattern of reviewing the imaging. It doesn't matter how you review it. Everybody has their own ways of reviewing scans, or they have their own template, but it's important that you review everything in that particular MR imaging. So we'll start with the first theme, which is trauma. And we're looking at the spine misses. So the first very important theme is trauma. And a very important principle in trauma is that minimal bone injury is often a sign of ligamentous injury. Now, what that means is that when fractures happen, especially even if you see in the extremities, the brunt of the injury goes onto the bones. The ligaments often don't get affected. So if you look at ankle, for example, you do the ankle, you have twisting injury, you do a radiograph, all you see is soft tissue swelling, but no fracture. And that is what happens because the brunt of the injury has gone onto the soft tissues, which is ligaments. Whereas same thing applies in spine as well. Whereas when fractures happen, often the blunt of the injury goes onto the bone rather than the ligaments. The next very important principle is that the resting position we image is not the position at the time of the injury. Now, particularly important, say for example, we have flexion, extension injury in the spine, different mechanisms of injury. We have to remember that when we are scanning, that's a static position. The dynamic position of injury, the flexion pattern, extension pattern, or whatever has already happened at the time of trauma. So we have to apply our mind when we look at the imaging. What is the pattern of imaging I'm seeing? What are the possible things that are possible in this particular case? Is it purely bony injury or can there be ligamentous injury as well? So very important to think about the mechanism of injury, any trauma in MSK. So let's start with the first case, an interesting case. This is a 16-year-old girl and she had injury while playing on the trampoline. And this was the CT scan which was done. So let's look at the CT scan. Um, I'm trying to scroll through the CT. Hold on. It's not letting me. I think it's going too quickly. Uh, I'm not sure if there is a way. Can everybody see my slides? Can everybody, Chinmay, are you able to see my slide?
Yes, sir. Yes, sir. I can see it.
So I've
Can you just
changed the
make it in?
setting. I've come out of the PowerPoint because I wanted to show something. So if you look at this particular case, this is 16-year-old girl who had injury on the trampoline. She had a CT scan. The CT scan was reported as normal, and then she was sent home. Now, if you look very carefully, what has happened here is she has very mild kyphosis at C5-6 level, and she has widening of the interspinous gap at this level. So very, very gentle change at this level. She's only 16 years old. Imagine she had significant injury to present to the emergency department and have a scan done. So she was recalled because of these subtle findings. She was recalled for MR examination. And on the MR examination, when she came back, she had complete disruption of the posterior ligamentous complex. So there is complete disruption. There is complete disruption of the ligamentum flavum at C5-6 level. There is diffuse interspinous edema. So this is a significant injury. You can imagine this is a case of pure ligamentous injury. And these are quite commonly missed because the CT scan can be reported as normal. The CT scan will only show very subtle findings, indirect signs like such as widening of the interspinous gap or very subtle kyphosis. So this is the next case. In this case, uh, interesting case because the patient has 46-year-old, has motorbike injury, and there is spinous process fracture. So whether this is a straightforward spinous process fracture or whether there is something more happening, we don't know. So because if you look at the pattern of the spinous process fracture, likely the injury line was extending anteriorly. So if you look at, this is the orientation of the fracture, the spinous process fracture, likely the fracture line was extending anteriorly. And so there were no other fractures in the spine. The whole spine was screened, no other fractures, and the patient was recalled for MRI examination. So if you look at the MR examination, that is the spinous process fracture. And along with that, there is complete disruption of the ligamentum flavum, making it a significant ligamentous injury. So it looks like a straightforward spinous process fracture on CT, but because of the way the fracture is oriented, patient is called back, has an MRI, and confirms posterior ligamentous complex injury. Now, this is another case. We see it in practice all the time. 68-year-old road traffic accident. Now, what you see here is there is extensive dish type changes. There is extensive diffuse ossification all over the spine. So very, very difficult, making it really difficult because there is degeneration change, there is all this ossification change, making it very difficult to pick up fractures. Now, therefore, it is very important that never sign off a CT scan trauma without looking at the reformats. So when you look at the reformat, it shows a small fracture here. So because we've seen the fracture and we are probably worried about this level on the CT scan, we were on the CT scan, we thought that there was a loss of fusion, partial fusion at C5-6 level. So we got the patient back for MR examination. Now, if you look very carefully, the patient has fused spine. So all we are seeing is subtle edema at C5-6 level. So this is all subtle edema. That's all subtle edema at this level. There's no edema here. There's no edema here. There is no edema there. There is edema across the fusion at C5-6 level. So what has happened is the patient has had trauma through the fused spine, and this is unstable injury and significant injury, and the patient had surgical fusion to repair this, because otherwise the patient will be left with instability and significant consequences. Now, when I spoke about these subtle findings on plain film, so if you look at this, there is only subtle kyphosis. This trauma, history of trauma, there is only subtle kyphosis in the lower thoracic spine. Patient has MRI, and you can see here there is complete disruption of the posterior ligament complex, complete disruption here in the ligamentum flavum, all interspinous edema there. And this is another thing we see all the time, which is called as rigid spine or fused spine fracture. So a patient has sternal fracture. There is complete stick type fracture across the fused spine. And these are very unstable fractures. They often lead to cord injury, epidural hematomas, and they often will always need repair. So it's a stick fracture because once this is fused, it behaves like a long bone. Like long bones break like that, the spine also breaks like that. Sometimes the fracture may occur through the middle of the vertebral body, breaking like a bone. This is other thing which we see commonly in clinical practice and often sometimes missed is this patient has ankylosing spondylitis. So what you can see here, there is pseudoarthrosis developing. The patient had fused segment, and now the fused segment is undergoing loss of fusion. So there is sclerosis, the fusion is lost at this level, fracture across this level, and diffuse sclerosis posteriorly as well. And there is widening of the gap between the vertebral bodies. This is an unstable fracture. So we've covered, trauma. We've covered rigid spine trauma. We've covered basically the ligamentous injuries. The other thing which can happen sometimes is the neural injury. Now, this patient had road traffic accident, motorbike accident, the spine looks pretty much normal if you look at the spine, but the patient had loss of weakness in the upper limb. And now, because there is loss of weakness in the upper limb, the patient has brachial plexus imaging. And when you see carefully, the patient has completely torn off the roots from the cord. So there is complete disruption of the roots in the cervical spine. There is traumatic meningocele. So traumatic meningocele here, pseudomeningocele, complete disruption of the roots here. So that is the other thing which can be sometimes missed. So depending on the trauma, subtle findings may be there in pure ligamentous injury, such as just widening of the interspinous gap, subtle kyphosis. History becomes very, very important. If you're suspecting brachial plexus injury, do proper sequences. And in rigid spine, be very careful. You might need both CT and MRI imaging. So coming to the next theme, which is disc abnormalities. Now, disc abnormalities are very, very common in clinical practice. And this is one area which is quite commonly missed because obviously a large volume of imaging is done because of disc problems. So important thing in disc abnormalities is that we should review all sequences thoroughly. What we see on axial sequences may not be visible on sagittal sequences, and what is seen on sagittal sequences may not be visible on axial sequences. And do remember that the common area where misses happen are in the foraminal disc and the extraforaminal disc, because these form each less than 4% of the disc abnormalities. The central and paracentral ones form more than 90%, and they're usually easily picked up. So let's look at some of the examples. This is a 51-year-old patient with radicular pain. And in our practice, typically, we do the axial imaging at the lowermost 3 levels in the spine. So it becomes really important when there is clinical history and otherwise to review the higher levels very carefully. So if you look at this case here, there is a small foraminal disc protrusion. That's the small foraminal disc protrusion, and that explains the patient's radicular symptoms. Now, in this case, if you look at 44-year-old with hip pain, the patient, this is normal. This is normal. The patient has a far lateral disc protrusion, and the far lateral disc protrusion is causing the patient's neural impingement. And this is treated with nerve root injection. Now, this is very subtle. The patient has tingling thigh pain. So if you look at the L3 level now, so there is subtle disc extrusion into the foraminal level at L3 level. So this is the L3 foraminal disc extrusion. So you can see how subtle it is. Normally, there is disc, there is neural, this is the nerve, this is the fat. Some people call it lamb chop. Nerve, fat, nerve, fat. Whereas when you look here, there is extruded disc material sitting into the foraminal region. And these can be very, very painful. And these can present acutely as well. So in this case, because we know there is tingling in the thigh, which corresponds to the abnormality at the L3 level. So this is the abnormality. This is the foraminal disc protrusion. So the next we look at the disc protrusion in the thoracic spine. So the thoracic discs, when they become quite big, the important thing to recognize is these are often calcified. So if you see a large thoracic disc protrusion, always recommend CT scan examination. That's what we do in our practice because we always find that these have large calcific component, as in this case. So when you look at the cervical spine, when the degenerative changes happen, it's disc osteophytic changes. Along with disc, there are osteophyte formation changes. Whereas when we look at the thoracic discs, when they are large, they're associated with calcific component. Now, this is another case where there is extensive degenerative change. And so when we look at the extensive degenerative change, So when we look at the extensive degenerative change, and we see a low signal component extending into the thecal sac. And when we keep looking at it, we find that there is a low signal abnormality extending into the thecal sac. And what is this? This is an intradural disc herniation. So let's look at it again. So basically what has happened is that the disc has extruded and encroached into the thecal sac. So what we see here is complete low signal material extending into the thecal sac through the dura, and this is intradural disc herniation. Now, just to show you that sometimes acute discs can be bright in color because they can have an hemorrhagic component. So if you look at this case, the patient presented 30-year-old with severe neck pain, and you see his bright disc extrusion component producing a cervical cord impingement. So basically, this is the disc extension outside with hemorrhage within it, and this was significant, and the patient needed surgical decompression. Now, this is standard. We see this all the time. This is sequestrated disc material, and sometimes they can be bright in color. They always don't need to be low signal. And this is sequestrated disc extending completely behind the L3 vertebral body. So this is example of another sequestrated disc. When you look carefully, there is a disc material which is extending into the roof of the foramina. So that's the pedicle here, and this is the extruded sequestrated fragment extending into the L3 foramina. So let's look again. When we look at the T1 sequence, we can see this low signal material extending into the L3 foramina, and this is a sequestrated disc. So now this one, looking at this one, this is a good example. Again, something we see all the time in clinical practice. This patient has extensive degenerative change all around. So when we look at the degenerative change, the patient has extensive degeneration. And then when we look through it, what we see carefully, this patient came in with hip pain. And when you look carefully, there is a large disc which is extruded at L1-2 level. Now, if you look carefully, essentially there is degenerative change all over, but the patient came with hip pain. And when you look carefully across the L1-2 level, there is extensive disc extrusion at the L1 level, which is producing the hip pain. So if you look carefully now on the axial sequence, so that's the extensive disc extrusion at the L1-2 level, which is producing significant neural impingement. Now, this is the large foraminal disc producing neural impingement. So next, moving on to this one, just look again, there is extension of disc material into the L2 foramina. That's the disc material, which is intermediate signal. And we keep looking on the, you can see there extensive disc material extending from the disc into the neural foramina. And as I already mentioned, these patients can present acutely with severe pain symptoms. And the surgeons don't like to treat them, so it's very important to pick them up. Often in our practice, we do pain relief or we do a nerve root injection. Now moving to the next one, this is an interesting case. If you look carefully at the L5-S1 level, so when we look at the L5-S1 level, there is a conjoint nerve root. And these are very common. These are incidental finding, and these are very common at the L5-S1 level. Now, when you look on the other side, you will find that the nerves are coming separately together. So that's one nerve, that's the other nerve. But when you go on the other side, you find that the nerves are coming together. This is conjoint nerve, and there is disc protrusion, which is compressing on the conjoint nerve root. So just to show you that it's not uncommon to see this kind of abnormality here. This is conjoint nerve root, and there is disc protrusion, which is causing impingement. So there's a disc protrusion here, which is causing impingement on the right-sided conjoint nerve root. So if you look again carefully, these two nerves, the L5 and the S1, are conjoined. That's the nerve, that's the nerve, and this is the disc which is compressing on the conjoint nerve root. So next, we will look at, so this is example of what the conjoint nerve root looks like. So this is the conjoint, that's normal nerve, and then this is the conjoint nerve which is joined together. So the important reason is sometimes these can be confused for disc material. So for example, if you look at this is the conjoint nerve root, but this is mistaken for other abnormality. So in this case, people think this is a disc protrusion. But when you do the T2 sequence, you can clearly see that this is just thecal sac here, and this is the nerve there. So we've seen two themes. The next theme we will look at is the degeneration in the facet joint. So let's look at the facet joints now. So this is the facet joint cyst, which is very common in facet joint pathology. And these are often filled with intermediate signal material. So this is the case here, where there is intermediate material within the facet joint forming facet joint cyst. And these can be treated by doing injections. So as in this case, there has been a steroid injection which has been performed into the facet joint. And this is another example where there is a facet joint injection being done. So there is facet joint cyst, which has been injected with steroid. And that's the facet joint cyst here. Now, the other common area which I find people miss is the lateral recess. Now, this is an area which lies medial to the pedicle. So that's the area. This is the facet joint degeneration. This is the area of lateral recesses. And this is one area where there can be neural impingement and it can be missed on imaging. Now, the lateral recess is one area which is bound medially by the pedicle, and it's affected by degeneration change, or sometimes, as you see in this case, where there is sometimes disc protrusion or facet hypertrophy. Either of these, they produce narrowing of the lateral recesses. Next is, it's one of my favorite topics. I always talk about this to my residents, is spondylolisthesis. Now, in itself, spondylolisthesis means nothing. It just means that there is slippage of the vertebral body, which could be degenerative, lytic, traumatic, or dysplastic. Now, we know the grading. We all love grading. So we have a grading as well. Grade 1 is 0 to 25%, grade 2, 25 to 50%, and so on. And now why it is important? Why it is important to understand spondylolisthesis is because if you say in your report what type it is, not only do you mention spondylolisthesis, but you say this is degenerative, lytic, traumatic, or dysplastic, it'll give the person a huge idea why this is happening. What is the etiology of the spondylolisthesis? So once we know about this, we will know what exactly to expect. So now let's look at the degenerative spondylolisthesis. So in this degenerative spondylolisthesis, what we typically see is that there is central stenosis. So if you look at this particular case of degenerative spondylolisthesis, there is this change at L4-5 level. And in this, what happens is because of degenerative change, the whole vertebral body slips forward. And when this happens, it leads to central canal stenosis. And this is a common thing which happens with degenerative spondylolisthesis. Now, the next type is the lytic spondylolisthesis. So what happens is there is pars defect posteriorly, which are not fused with each other. And what this leads to is forward slipping of the vertebral body. So when the forward slipping of vertebral body happens, is the central canal will never become narrowed. In fact, the central canal becomes elongated. So when we were talking about degenerative spondylolisthesis, we were talking about central canal narrowing. When we talk about lytic spondylolisthesis, the moment you mention that, I know that the central canal will never be narrowed in lytic spondylolisthesis because this moves forward, this stays behind. Now, the next thing is the traumatic. So this is the traumatic and dysplastic spondylolisthesis. The dysplastic spondylolisthesis, this one happens because there is abnormality in the facet joints at the L5S1 level, and this typically happens at the L5S1 level where the facet is dysplastic. Now, this typically happens in women when they're moving from adolescent to adulthood. So what happens if you look carefully, this almost looks like lytic spondylolisthesis, but the dysplastic facet, which is this facet, is dysplastic. It is not able to hold the L5 vertebral body. This is small. The orientation is poor. And when that happens, during adolescence to adulthood, this slips forward. And when this slips forward, it leads to severe narrowing at the L5S1 level of the central canal. So, important points. The moment you mention spondylolisthesis, think, is it lytic? Is it degenerative? Is it dysplastic? The moment you think of central canal stenosis, it has to be degenerative. The moment the central canal is widened and there is narrowing of the foramina, it has to be lytic. The moment you see dysplastic facets at L5S1 level and there is slippage and narrowing of the central canal, it is dysplastic. Now, traumatic spondylolysis is typically seen in young patients. So, for example, patient is young, patient is a fast puller, and you see these trauma or stress injuries in the pars. Now, this stress injury can propagate to complete fracture. And when that happens, they can just behave like lytic spondylolisthesis. So let's look at this case here. This patient's a fast puller and patients having stress changes in the L4 pedicle, in the L5 pedicle, bilateral, in both two levels. And at one of the level, this has now propagated to complete fracture. So I've already covered this chart. This is a chart which I find it very useful. I teach all my trainees using this chart. Degenerative, key finding degenerative facets. Central canal will be narrowed. Lytic, pars defect, central canal is never narrowed. It's elongated. The foramina will be narrowed. In dysplastic, L5S1, dysplastic facets, and the central canal will be narrowed. So we've looked at these spondylolisthesis theme. Let's move to the stress injuries. Stress injury means insufficiency fractures in the elderly and apophyseal fractures and past stress fracture in the children. So, for example, interesting case, 76-year-old with stenotic symptoms with the recent acute exacerbation of lower back pain. Now, this patient has central stenosis. Everybody knows about it, the patient's managing well, and then suddenly comes with back pain, low back pain. So we know about the stenosis. There is degenerative spondylolisthesis. There is stenosis. What we see is there is subtle fracture. So if you look at the sacrum, there is edema here, and on T1 there is a fracture line. So the main reason patient has now presented is sacral insufficiency fracture. Another example, patients had previous operation, patient has severe degenerative change, has had loads of MR, and now comes with worsening of symptoms. And what you see is typical same changes, previous operation, but at the margin of imaging, on T1, you see some low signal changes, extensive low signal changes, more low signal changes in the body of sacrum. So the patient's brought back for CT pelvis, which confirms sacral insufficiency fracture. So the main reason for current presentation is not previous surgery, not degeneration, it is the sacral insufficiency fracture. Now, young children, very common to have stress, especially when they're active at the apophysis. So this one patient was a gymnast. patient was having back pain, and the patient came back with the transitional lumbar vertebra level. There was pseudoarthrosis with extensive edema changes. So if you look at the level of pseudoarthrosis, there is marked edema bilaterally. So that's stress changes at the pseudoarthrosis. I've already looked at past stress fracture, typically seen in weightlifters, bowlers, and this patient comes with pain. There is edema in the pars, and when you do a CT scan, this is what we see typically. This is incomplete small pars stress fracture, and typically when they happen, the early fractures happen in the lower part of the pars, and when they keep on increasing in size, they can extend to full thickness, and then they can progress to non-union. So this is small, early, incomplete pars stress fracture. When we only see edema, we call it pars stress changes. This is 16-year-old, very active patient, comes with pain in the thoracic spine. Patient seen to have changes in the transverse process. And obviously, we have to think of osteoid osteoma. So we progress to CT scan examination, and the CT scan shows that the apophysis is separated. There is gap. So this is stress apophyseal injury rather than osteoid osteoma. The next very interesting theme is inflammation. We will also cover infection in this. One thing which I find all the time is because of the way inflammation happens or infection happens, we often do not do the right sequences. And typically, because of seronegative spondyloarthropathy in young patients, we miss it all the time. And in one literature, it was mentioned that the average delay in diagnosis of axial spondyloarthropathy or ankylosing spondylitis is sometimes 7 to 8 years. The reason is these are young patients, they have low back pain, they have non-radicular back pain, and they have back pain which gets better with anti-inflammatory medications. So they just keep on dragging it. And because they keep on dragging it, by the time they actually present for imaging, it can be, the story can be quite later. The movie would have moved to beyond the interval level. And that's what happens in these patients. So we will look at few examples here in what spinal imaging where the radiologist can give a hint and say, get the patient back for seronegative spondyloarthropathy protocol imaging. So let's look at examples. I will also look at some of the SAPHO examples, which is much rarer. But again, as radiologists, because we are doing spine, we have to be careful about these things. So this is all from my routine practice. This is the case, 49-year-old male, 1 year history of back pain, non-radicular back pain, now referred by GP for lumbar spine MRI. So we do the standard lumbar spine MRI, but we see a lot of anterior corner fatty changes, fatty change, fatty change, fatty change, end plate change, possibly end plate edema, because this is low signal on T1, high signal on T2. So we are not happy. We say we need to get the patient back for SI joint protocol imaging. And the moment patient is brought back, we see extensive costovertebral edema, corner edema, aseptic spondylodiscitis changes. The sacroiliac joints have already fused in this patient. As I said already, the story has gone beyond now different level. So the patient must have had these changes for years. By the time the patient is now presented, the SI joints have already fused, and we are now seeing active changes in the spine. Another example, 48-year-old has low back pain, stiffness in the hands, and then patients referred for cervical spine MRI or maybe some cervical neural compression or lumbar neural compression. So what we see is fusion, 2, 3, 4, 5, 6, 7, 6, 7 fusion, fatty changes, a bit of edema, and in the corners, in one of the corners, we see a bit of costovertebral edema, and this, makes us think, wow, costovertebral edema. Now, costovertebral edema, if you see, it's a very specific sign. a very important finding which should raise possibility of seronegative spondyloarthropathy. So we get the patient back for and obviously, sorry, the patient's lumbar spine had all fatty changes all over anterior corner. We get the patient back for SI joint protocol, extensive costovertebral edema, corner edema. It's all over the place, corner here, corner there, and then costovertebral edema. Patient has florid sacroiliitis, seronegative spondyloarthropathy. Now, just to show you again, this patient, how this patient was mismanaged because of not anybody's fault, but it's a learning experience. Patient is 30-year-old, comes with back pain. Patient has these changes at L3-4 level, end plate changes, edema, end plate irregularity. So we think of all sorts of things, mechanical degeneration, atypical infection. Patient has whole spine MRI imaging, nothing is found. Patient has end plate biopsy to look for a typical infection. Still symptoms keep going on. The surgeons decide to fuse it. The surgeons go ahead because of these changes, they fuse this level. 1 year later, the patient comes back with this. The patient's symptoms are continuing, but now at this time, he has a lot of corner edema. Luckily, he has done imaging at this time because of metal work. And there is corner edema every year. The radiologist raises possibility of seronegative spondyloarthropathy, and the patient is brought back for SI joint imaging. There is florid sacroiliitis. So you can imagine what we saw the first time. This was all aseptic spondylodiscitis, which landed up having fusion. And 1 year later, we find out the patient had nothing but seronegative spondyloarthropathy. This is another interesting case. Patient has cervical neck pain, thoracic pain, scapular pain, and the patient has cervical spine imaging, interscapular pain. There are some degenerative changes, very common in cervical spine. And in the corner of the imaging, now corner of the imaging, on one or two slices, we find that there is edema at the clavicle, at the costovertebral joints. There is costochondritis. And because of this, costochondritis change, the patient is brought back for further imaging, which shows osteitis in the sternum, changes at the clavicle, medial clavicle, some changes in the anterior corners with normal sacroiliac joints. So I phoned up the patient and asked, what exactly is happening? Have you had any other investigation? The patient says, I've had my hand biopsy done and I had palmopustulosis. Well, you got the diagnosis there, isn't it? Nobody has put this together. So the patient's been roaming around to dermatologists, been going to the neurologist, and finally we tell them that this is nothing but Sapho syndrome. So you can see how radiologists can add so much to the imaging. So don't forget the corner of the imaging. Very important. If you want to read more on the Sapho syndrome, there is an article in the Indian Journal of MSK Radiology. It is freely accessible. So you can just Google Sapho IJMSR and you will get it. I was one of the authors of it. So you should be able to get it. Another interesting case, 68-year-old female comes with occipital headache, radiating down the arm, question mark, facet joint involvement. So patient has plain radiograph. Plain radiograph shows this weird calcification centered at the facet joint. Obviously, there are degenerative changes at the facet joint. There are degenerative changes in the cervical spine, but we're not sure what exactly this is. So we get the patient back for CT scan. I will have to come out of the presentation just to show you the CT scan. So when we look at the CT scan, there is all this kind of calcinosis centered at the facet joints. So let's look at that. Extensive calcinosis centered at the facet joint, producing severe foraminal stenosis. Now let's get back to the presentation. Pointer again. Yeah. So what we have found is extreme calcinosis, severe foraminal stenosis. So we go to the radiology information system, we find out that the patient has somewhere mention of systemic sclerosis. We look at all the other imaging. She's had some other imaging. There is no ILD. There is no other calcification anywhere in the body. So this is the patient's first presentation of intraspinal calcinosis, which can be seen in patients of scleroderma. And we know that the patient's already got systemic sclerosis. So you can see how much we can make the difference. Another interesting case, 25-year-old male, he came to the A&E following a fall. Because he had a fall, he luckily had CT scan done and plain radiographs done. So on the plain radiograph, they couldn't see much. So they went ahead with the CT scan. So when the CT scan was done, I will have to come out again. Just to show you, the CT scan was reported as no fracture, but what caught our eye was the abnormality at the facet joints. So we thought there was something wrong with the facet joint. Patient's very young, so the patient should have MRI. So the MRI examination was recommended. So this is the abnormality on the facet joint. Let's look at the pointer. Yeah. So that's the CT scan. There is marked abnormality at the facet joint, marked abnormality at the facet joint, something there possibly in the foraminal region. If I overshoot, do let me know because I've got lots of cases.
No, sir, we
This
have
is,
10
yeah,
minutes at least.
yeah. So basically, we see abnormality on the MRI in the facets. We see something. So how do we look at it? We see that the abnormality is centered at the facet joint, which is erosion. There is soft tissue component. So if you look at that's erosion, and there's a large soft tissue component, large soft tissue component. So is it a tumor? Is it something else? Well, we don't think so. We thought because this is young patient, this is a joint-based abnormality. This is involving two different joints. There is soft tissue component. We raise possibility of gout, and we asked them to check uric acid level. Now they come back and say, oh, well, the uric acid is markedly elevated. Patients markedly obese, 146 kilogram, and then the DECT is performed, which confirms spinal gout. So for him, good thing is he had a history of fall and he had a CT scan, and the radiologist was able to diagnose gout. So do remember that you can see strange things in the spine. Now we will go to the satisfaction of search. So this is the plain radiograph. We always talk about pedicle. So in this case, the pedicle is missing at the L4 level. Pedicle is missing, just visible on the AP radiograph. CT scan is done, which confirms a large neoplasm. There's a metastatic disease involving the L4 body and the pedicle. So satisfaction of search, very important. Another case of satisfaction of search, we pick up a neoplastic lesion in the L4 vertebral body. Patient does not have history of known malignancy. We do the whole spine imaging, and at the corner of the imaging, we can see a lung tumor. So that's the lung tumor. Patient has CT scan, confirms lung tumor with bone metastasis. Now this one, I see it all the time. I'm sure this is not really missed, but it is something important where quality of imaging is very important. So the only thing that really matters in degenerative cervical spine is central stenosis and myelopathy. Foraminal stenosis is common and not always operated. Very few cases of foraminal stenosis get operated. Most cases get operated because of central stenosis and myelopathy. So it's important to pick up myelopathy. If you look carefully, this is the T2 imaging, but very carefully, there is very subtle high signal change. So stir is done, good quality stir, T2 fat saturated, which shows the edema at this level. So in central stenosis, important to pick up myelopathic changes. Now this is another interesting case, 45-year-old with severe radicular pain. Patient is young. There is degeneration at L4-5 level. There is a large disc extrusion. You can see that. That's a disc extrusion which is compressing the left S1 nerve root. Now, patient, obviously this is reported. Patient comes back a year later with paralysis. And at that time, the patient is noted to have diffuse cord edema. At that time, we see these large vessels within the central canal in the chorda equina. Essentially, patient has spinal dural AV fistula with cord congestion. And if you look at the previous imaging, it was there. This linear vessel was there. But because the focus was so much on the large disc extrusion, this was kind of thought of as possibly not very relevant and very easily missed. So this wasn't called at that time. And when the patient came back with this, obviously at this time now, it was picked up. This is patient having a headache and cervical spine problem, neck pain, other things. Common area I find which can be missed is the fourth ventricle. So this patient has a tumor at the floor of the fourth ventricle. So this is a common review area because focus can be here. This area can be easily missed. Signal changes here can be easily missed. Now, this one is another thing. I'm sure it's common in different countries. So what we see is central canal is along, wide. There is no significant abnormality. If you look at the first read, the spine looks pretty much normal. But if you look carefully, this is too much low signal change here. And we see empty thecal sac sign. This is all the nerve roots are abutting or clinging together to the dura. And on the CT scan, there was calcification. So this is arachnoiditis. And these can be cause of chronic back pain, chronic radicular pain. So I already showed you examples. Do not stop at the most obvious abnormality. Continue with review areas. The scan looks normal on first screening. Spend extra time on it. Now we have the theme, other theme. I will not tell you the theme now. We will look at this theme. We see it all the time in clinical practice. Now, 77-year-old worsening back pain, known to have spinal stenosis. Patients had MR in 2017. This is what it looks like. L5-S1 level, severe degeneration. Now the patient comes back in 2019, which is here. And this is the MR imaging. This is T1 and this is T2. So on the T1, we feel that there is now some end plate irregularity. And on the T2, there is possible fluid signal change, which was not there on the previous MRI. So comparison is very important. We are not happy. We get the patient back for a follow-up imaging. So follow-up imaging 2 weeks later shows florid spondylodiscitis. So look at the T1 imaging. T1 imaging is the most important imaging for picking up early infection, where you will see end plate signal changes. So if you look at this is normal T1 signal, look at the end plate here. The T1 shows replacement of the normal signal, and there is florid spondylodiscitis. Now this one, 65-year-old with back pain, we can clearly see there is abscess, there is spondylodiscitis, but along with that, we cannot see the outer margins very clearly. So we get the patient back for CT scan, and CT scan shows a large mycotic aneurysm. The infection from the spine has gone to the aorta. Another example, we see it all the time in our practice. Older patients come with back pain, new back pain, or their blood culture is growing different pathogens and they're having back pain. When you look at this one, very difficult to call any infection. So in our practice, if there is suspicion of infection, we get them back again in 2 weeks. And you look at the MRI now. So 2 weeks earlier, nothing. Now florid spondylodiscitis. And I already mentioned earlier at the beginning, right sequences. So stir is very important. Sometimes we do not do stir in practice, clinical practice, because we're thinking of degenerative process, especially in practice in UK. Stir is not always done. Whereas if you look at this, stir is done here, it picks up the infection more easily. This is facet joint infection. And on the T1 and T2, it can be quite difficult to pick up because of the paravertebral musculature. So my theme in this one was infection. When in Rome, do as Romans do. Look at the geographical location. What is more common? So in our setting, spondylodiscitis is very common because of bacteria. And you have to look at the geographical setting, whether it's TB, brucellosis. And as I already said, if you suspect early infection, if you suspect subtle changes, don't hesitate to get the patient back in 10 to 14 days time, and always consider biopsy. So look at few more examples. This is 45-year-old patient with neck pain with radicular symptoms. There is degenerative disc osteophytic bulge, C5-6 level. And at the corner of the imaging, we suspect there is something going there. And what we find here, there is a vertebral loop. See that? Sitting in the cervical foramina. And this can happen sometimes. This patient has several weeks of back pain. Spine looks completely normal. And you can see there is a large, subtle, subtle in the sense, small leaking aortic aneurysm. That's the aortic aneurysm. And patients now coming with back pain. Needs emergency surgery. And another thing is satisfaction of search. This patient comes with back pain, has degenerative spondylolisthesis. There is moderate central stenosis, lateral recess stenosis, neural compression. But at the edge of the imaging, we see abnormal renal abnormality, which doesn't look like a simple cyst. Get the patient back, there is a large renal neoplasm. I probably pick up a renal neoplasm once every 2 years or something. Not very uncommon. And so the last thing is just to show you one very interesting case is how the radiologist can add twist in the tail. We keep adding twist in the tail all the time, and how it can be so helpful to the surgeons in managing these patients. So this is a 40-year-old patient. Patient has L3 known atypical hemangioma. The patient was treated with vertebroplasty. So that's the cement been injected into the hemangioma. Now, 6 months later, patient comes with worsening back pain. So the surgeon's obviously worried about infection. The surgeon does an MRI, and what we find on the MRI, the new finding. So if you look at the previous one, the end plates were fine. There was nothing here. Whereas if you look at this one now, there is end plate signal change edema, disc edema, and there are some new signal changes, some new bone formation changes anteriorly. So we're worried whether this could be infection or not, but equally, can this be a septic spondylodiscitis? We don't know. Luckily, this patient also had a CT scan for evaluation of the cement because the surgeon wanted to see if the cement had gone out. And the CT scan was done, and the CT scan showed this syndesmophyte, which is fusing all over. And at the very edge of the imaging, what we saw was there were erosive changes at the sacroiliac joint. So overall, all these changes are now because of aseptic spondylodiscitis, not septic spondylodiscitis. And we change the diagnosis, then the management becomes management of seronegative spondyloarthropathy and not infection. So, as I already said, we saw a lot of cases where the radiologist twists the plot, and which can be very, very useful in patient imaging management. So we looked at various things. We understood the pitfalls. We looked at some variants. We also looked at example of where we need to look beyond the bones and the disc. In my practice, I always try and avoid confusing terminology. I recommend appropriate tests where needed, not always. And very important to go by the clinical history. If you have previous examination or if the patient has previous imaging, ask for it. And if you're not sure of anything, don't hesitate. Ask, phone a friend, ask anybody, who is a specialist for an opinion. And that will be a huge saving for the patient and a big learning exercise for yourself. And very quickly, I think Chinmay already mentioned about the Prime Red platform I've been running. And we have launched a Prime Red Spine Fellowship, and we are taking currently students into it, the fellows into it. It will run over 3 months. It will have a lot of things with global faculty, full 50 cases, and 14 spine subjects to be covered. And the fellowship is launching from the 1st of February. So if anybody is interested in learning more about spinal imaging, you're welcome to come and join us. Thank you all very, very much.
Thank you, sir, so much for that amazing session. We just felt that you should just keep